So it looks like we're right at 12 p.m. Central, so we'll go ahead and get started with today's webinar. My name is Larissa DeLuna with the American Heart Association, and I'm happy to welcome you to the third offering of the American Stroke Association's webinar series. These educational webinars are being brought to you by the Southwest Affiliate Stroke Committee. For a full list of upcoming webinars, visit heart.org/SWA-quality. Before we get started, I'd like to go over a few housekeeping items. To avoid background noise, all lines have been placed on mute. For questions, you can unmute your line by pressing *6 or type in the Q&A section of WebEx. Although this event is not CE accredited or CME accredited, attendees will receive a certificate of participation as proof of attendance. All slides, handouts, and participation certificates will be sent to attendees within 1 week of today's call. Also visit heart.org/SWA-quality to view a recording of today's webinar. Today's webinar will cover stroke research with speakers from the Lone Star Stroke Consortium. Dr. Mark Goldberg is chair of the Department of Neurology and Neurotherapeutics at the UT Southwestern Medical Center in Dallas and site leader for the Lone Star Stroke Consortium. He is a vascular neurologist and lab scientist interested in cellular molecular mechanisms of brain injury and repair. Dr. Goldberg serves the American Stroke Association as a member of the Southwest Affiliate Stroke Committee. Dr. Stephen Warwick is a vascular neurologist and clinical scientist. He is currently professor of neurology at the Dell Medical School, University of Texas at Austin, and director of the Seton Dell Medical School Stroke Institute. He is best known for his research contributions related to the introduction and validation of diffusion and reperfusion MRI for stroke diagnosis, treatment selection, and outcome assessment. He has had leadership roles in many multi-center stroke clinical trials over the last 2 decades. He is a member of the American Heart Association Southwest Affiliate Board and is the current chair of the Lone Star Stroke Research Consortium. Michelle Provencher is a nurse and clinical researcher. She is currently the Research Clinical Manager for the Stroke Division of the University of Texas Southwestern Medical Center and the University of Texas Southwestern Medical Center's Program Manager for the Lone Star Stroke Consortium. She is currently the lead coordinator for the Lone Star Stroke's first multi-site study, nursing-driven acute stroke care, and has successfully initiated multiple studies in hospitals across North Texas. So I'll turn it over to Dr. Goldberg to get us started.
Thank you, Larissa. Good afternoon and welcome to the stroke webinar. My name is Mark Wahlberg, and we have pictures of all of us here, hopefully that you can see. I'm a stroke neurologist and neurology department chair at UT Southwestern Medical Center in Dallas, and I'm a member of the stroke committee for the Southwest Affiliate. In the Southwest Affiliate, we've got outstanding dedicated stroke providers across, I think, 7 states. And the goal of these webinars is to encourage open communication amongst our providers and to share the best practices that we've learned as we try to improve stroke care for our patients. So today's topic is research. We're all aware of the transformative changes in stroke practice that flow from hard-fought clinical research discoveries of the last decade. From the TPA trials of 20-plus years ago to the pivotal trials of efficacy of endovascular clot retrieval, stroke research improves the care we deliver, and it changes how we deliver it. And as we know, many large stroke trials require hundreds or thousands of patients, and they cost millions of dollars. These big trials are sponsored by the National Institutes of Health or major drug and device companies, and they're often carried out in big urban academic centers like the one where I work. Of course, most of our stroke patients in each state are not seen in these large academic centers, and many of our brightest minds in stroke care don't provide their care in these settings. Stroke patients should be able to access the latest in stroke research wherever they are, and stroke providers should be empowered to seek improvements in the care we deliver in any setting. So the goal of today's webinar is to provide some best practices and some lessons learned for incorporating stroke research into everyday stroke care, including our stroke networks. We plan an interactive webinar in 3 parts. First, we're going to hear about the Lone Star Stroke Consortium, which is a Texas state-funded alliance to improve healthcare through better access to stroke research across the state. Dr. Warwick will present that. Second, Michelle Provencher, our emergency room nurse and clinical research manager, will describe her experience in setting up stroke research programs, often in small rural hospitals, which have not had research practice before. And finally, Dr. Warwick will involve your participation in planning for a future stroke study. We're looking for an open, interactive presentation. At any time, I think, you can press the chat icon in the top right corner to ask your questions or send comments. We will also be inviting your participation through polls. And every time you see a vote icon like this pink one up in the top corner, it means it's time to vote. So you should use your WebEx to poll, and hopefully we'll try this. So if you please do choose an option, even if you're not sure. There should be an option for everybody. And as soon as the poll expires, or as soon as we have enough votes, we'll give us the group tally. So be patient with us as we work through it. We'll start with just a test poll. Here it goes. And be prepared to answer. Here they are. These are their choices. My 2018 New Year's resolution: A, exercise more. B, show gratitude. C, eat more pie. D, get more sleep. D, no more resolutions for me. Okay, so let's see. Now comes the part where some answers should appear. Let me see. Okay. In the top right corner, if you click polling, you should get your options, and now would be a good time to give your choice. Although it says the poll is ended, so I don't know. First, can we start? There we go. We are live.
Here we go.
Okay, here we go. And we would like to do each of these polls, since there's quite a few, in 20 seconds. So hop to it, give your best answer, and we'll see where it takes us.
And then hit submit, the submit button on the lower right.
Submit, thank you. All right, my vote's official. Larissa, how many do we have so far?
We have about 45, so I'll go ahead and close the poll.
Awesome. Okay, this is a good start.
So with trend, it looks like everyone's New Year's resolution is to exercise more.
Wait a minute. Where is the result?
Can we see the results?
Yes, so they're WebEx is aggregating them right now, so they will show up on the screen in about 2 seconds. Let's see. Do y'all see them?
Not yet.
We'll try it with the next one and see if I can display this.
All right, we're moving on to some actual real information. We'd love to know who's here on our call, and that's going to help us understand the topics. So let's start by just figuring out where we are. I believe these are the states that make up the Southwest affiliate. I wonder if I missed one. But anyway, if you would, look to the, hoping that the questions will appear on the right, and just identify which state you're in. And there we go. Pick your state. And looks like we also are going to ask you to answer the next question, which is what your role is in stroke care. A, nurse. B, therapist. C, coordinator. D, physician. E, other. F, administrator. G, none of the above. So if you would, also indicate where you're coming from in stroke care, and then click those, identify those two answers and hit submit.
Okay, it looks like we had about 49% from Texas, with 13% from Arkansas, and most are stroke coordinators or other.
What percent physicians? What percentage physicians do you have?
It was low, probably about 2%, 2 to 3%.
Okay.
Okay. All right. Well, at this point, if you want to send in any comments about who you are and how you got to be here, please go ahead and identify that in chat. Go ahead and type that in, send it to everybody, and this will bring us up to date about who exactly we have. So, okay. Now, okay, last question before we get started. Try to understand what our practice is, and these are several simple answers. A, most of my work is in A, an academic medical center or hospital, B, an urban hospital or practice, C, a rural hospital or practice, D, none of the above. And you get to decide what's urban and what's rural. Okay. Do we have an answer?
Yes, it looks like most are in an academic medical center or hospital. Then followed closely by rural hospitals or practices, and then urban hospitals.
Okay, good. And we had one response for the other. The person wrote in there, research coordinator and data registrar, which means that someone who's already deeply involved in research, which is terrific. Okay, so I'm going to turn it over now to Dr. Steve Warrock, who's going to give us an introduction to the Lone Star Stroke Consortium. Steve, please go ahead.
Thanks, Mark. So Lone Star Stroke was an idea that came about from a discussion that Dr. Goldberg, myself, and other colleagues in the 4 major Texas cities had back in 2012. So at each of those sites, there was a senior experienced stroke clinical investigator, and therefore it was a natural thought that we all had is, wouldn't it be great if we could organize a research network across the state? For reasons that Dr. Goldberg alluded to, the 2 among those reasons are that we all know that the latest advances in stroke treatment and management come from research, and research is therefore a way for centers and hospitals to be participating in the cutting edge of stroke therapy before it's generally available. There's also a great need to be able to generalize the work that we do, and so we want the results to apply and be adopted more than just in the big urban academic medical centers. So we wish to involve hospitals that did not have a lot of experience with clinical research. One of the aspects thematically that we were interested in early on was the use of video telemedicine, both as a research topic and as a tool toward using in clinical research. Here we go. So we came up with the idea of Lone Star Stroke with the goal of trying to improve the health and lives of Texans through this statewide network of research facilities that linked the major academic medical centers to community and rural hospitals by a kind of hub and spoke model, believing that the network and the research it produces will raise the standards and provide better care for people suffering from stroke or at risk from stroke all over the state. So our approach was to make I'm going to skip to here, to make a request to the state legislature And I think in terms of the practical parts of this, one of our members had contacts with state legislators, physicians who could be our legislative advocate and legislative champion, and that really was a big plus for us. And so folks in other states who may want to do something similar with their legislation, I think the key would be to identify a legislator, hopefully somebody with a medical background who will really champion the idea. We had the idea in 2012. We made the proposal. The legislative session in Texas, which happens every 2 years, approved it and funded us beginning in 2013. And every 2 years, we go back to the legislature and make another funding request, and therefore we're highly motivated to show our progress every 2 years. Right now, this map shows where current, it's actually, we have a couple more that are on the map, but it gives you a sense of Lone Star Stroke institutions. Notice by the different colors that we are centered over the largest cities: Houston, San Antonio, Austin, Dallas, and we started with those 4 hubs. We now have 6 hubs. The yellow markers in West Texas represent Texas Tech Health Sciences Center in El Paso, and affiliated with the campus in Lubbock as well. There's Dr. Goldberg Institution of UT Southwestern in Texas, mine, Seton Healthcare, and Dell Medical School at UT Austin. There's UT Health Sciences Center San Antonio, UT Health in Houston, as well as Baylor College of Medicine in Houston. And each of these hubs have their group of so-called spoke hospitals we work with and do clinical trials in that network. As I said, we began with the idea and the goal of using telemedicine as a unifier, as a way of using it as a research tool, a research topic, but also as a mechanism for beginning telemedicine relationships that didn't exist. For example, our campus in Austin did not have a well-developed telemedicine program, whereas UT Southwestern, UT Houston did. We subsequently decided to expand the range of studies beyond those that use telemedicine. And let me give you some examples of the studies. Was already alluded to that the first multi-center study in the network out of UT Southwestern is looking at this nursing-led pit stop model for doing telestroke consultations to see whether that improves the time to treatment as well as, therefore, the outcomes in those more remote hospitals from the telestroke hub. We have a telemedicine or telestroke registry that is collecting data on times to treat and outcomes across the state where telestroke consults are happening, to better understand issues of access and how to optimally use the technology. Another of our centers from Baylor College of Medicine is using remote video teleconferencing to help patients with self-management of risk factors to prevent subsequent stroke. There are 2 of our groups, both UT Southwestern and Houston, have been investigating across the state where are the needs for research, where are research disparities, finding that up to 50% of Texans lack access to stroke research. When you think about the big news this year in acute stroke therapy of thrombectomy and later time windows, this was happening for several years in the research site. So having access, being a participant in research, is really a way to get access to novel therapies before they'll be generally available. We have begun a study looking at the brain scans of women with stroke to understand why men and women have different stroke severities and outcomes and maybe different responses to stroke, looking at, on the scans, the arteries and the collateral circulation as well as the brain perfusion. There's another project investigating the value of transferring patients with intracerebral hemorrhage from the smaller remote hospitals into the main hub, trying to answer the question, in which cases is it really a benefit, in which cases is it better to keep the patient at their own hospital. And I'll spend more time on this last point later. This relates to a study that we're really in the early pilot stage of looking at what is the best time to start an anticoagulant after a patient has had a stroke due to atrial fibrillation. We'll talk more about that later. And I'm going to pause this part one and take any questions that come before we go on to the next part with Michelle. And I may need some help identifying whether there is a question. And if not at this point, we'll have a chance later. And let me.
There's no questions in the WebEx Q&A section. If anyone would like to come off mute with *6 to ask the question, feel free.
And we'll have a chance at the end. So let's move on to Michelle's presentation.
Oh. Thank you, Dr. Warwick. I appreciate it. So as the introduction alluded to, I'm one of the program managers for the Lone Star Stroke Consortium. As Dr. Warwick mentioned, there are 6 hubs now within Lone Star Stroke, and so I am just over UT Southwestern in Dallas. Oh, I think we skipped one. Hold on one second. Okay, so to get us started, just kind of want to look at everyone's role in research. So one more poll study for you guys. That should be popping up on your right. All right, Larissa, how many responses do we have?
So we had the majority already participate in research studies and trials, or would like to participate, but there's no ongoing research opportunities at their workplace.
Perfect. So most of the people on the call are already doing research. We are going to gear this section a little bit more towards those who want to do research and haven't done it so far. I don't think it's, there we go. Okay, so we're going to look at research versus quality improvement, or QI. So what is research? Most of the people on the call then should already know that research is going to be that systematic investigation, and it's really designed to create this generalizable knowledge. The quality improvement piece is usually using proven methods to improve on metrics that we are already measuring. So the design is a little bit different, and then the knowledge is, again, generalizable for the research part of it. So this breaks it down a little bit more into the different elements of research versus quality improvement. So if we look at the intent, again, the human subject research is really wanting to get knowledge that is generalizable to either other patients or other hospitals, whereas quality improvement is just improving on patient care using methods that we already know are beneficial to those patients. So again, that changes the design between the two. And then if we looked at the effect of the program, we know that research doesn't specifically improve that program or institution. However, it may influence future policies in that hospital. whereas quality improvement, we're using things, again, that we already know work, and so the effect should be there. We anticipate that effect going into it. And so if we look at the populations are a little bit different. For research, we're using a subset of individuals and making sure that the individuals we're choosing help us meet our endpoints at the end of the research study. And so your population is different for research. Again, if you look at the quality improvement population, it's usually inclusive of everyone that's getting that treatment or that specific process. Now, when we look again at the benefit, this kind of goes back to the effect. For research, we're expecting that the individuals may or may not get benefit from this one particular study. However, again, it may develop into something where we can benefit patients down the road. Quality improvement, again, we're using things that have already been proven to be beneficial to patients, so we do expect that they will receive benefit from whatever that activity is. Now, the dissemination of results and publications also a little bit different between research and quality improvement. So, as I mentioned already, for research, we're looking for generalizable knowledge that can be applied in other places across the globe versus quality improvement. It might increase the likelihood of us looking at systems and models that might benefit other hospitals, but again, not necessarily generalizable knowledge. So another research question, another poll question, what is research? So which of the following projects qualifies as research? I'll give you guys a few more seconds to answer that one. All right.
It looks like most answered B.
Good, which is the correct answer. So the difference here for a survey of stroke preparedness among emergency department staff for the review at a monthly meeting. So just because you're doing a survey doesn't necessarily mean it is research. A randomized trial, that's kind of a key word there, of stroke recovery drug, that's definitely research. Monthly education for EMS teams with pre- and post-class testing, that can be more quality improvement. Again, we're using something that we've already established as a proven method, and we're just using that to improve whatever the process is. So it doesn't necessarily constitute as research. Okay, so what makes a good research question? The question needs to be relevant. We need to make sure that there is a need for improvement on whatever we're looking at. It has to be able to be testable and feasible. When you create a hypothesis, you need to make sure that the hypothesis is something that can be accepted or rejected, so it needs to be falsifiable. And then an interesting research question. So we want to know what happens when we do X, Y, or Z, and we want to make sure that people are actually going to be interested in the results. So what are some of the barriers in your guys' institutions right now? So in my environment, the major obstacles to starting a stroke research project would likely be, and we'll give you a few more seconds for that one.
So it looks like we have a three-way tie between cost, my time and staff time, and not enough patients.
Perfect. All right. So we're going to delve into some of the other barriers and some things we can do to get around some of the barriers, not all of them. So the very first one is making sure that you get research buy-in. So this wasn't on the top ones, which is good. sounds like most of your institutions already adopt research. There are some hospitals out there that are more resistant to doing research in the facility, so it's good that you guys have those where you can actually do it. But making sure at the very beginning of a research project that you do get the buy-in necessary in order to move that project forward. So whether that's hospital administration, specific committees like your stroke committee, physician buy-in, nurses, research staff, other hospital personnel such as your stroke coordinators or quality improvement managers. It's very important to make sure that we're getting that at the very beginning. And then again, looking at your feasibility data, so making sure that you have the number of patients there. And for different sites, you have different databases that you can tap into. So some hospitals have diagnosis-specific databases such as stroke or trauma. Get With the Guidelines is also another good one. That's a national database. And then for some hospitals that don't have any of the above databases, their hospital billing team can pull discharge diagnoses. So it's kind of a workaround, and it requires a little bit of sophistication on the hospital's billing team and also their software that they use. But I know we do that sometimes at UT Southwestern. We're using discharge diagnosis to identify how many patients we had of whatever type of project we're looking for. Now, once you get the feasibility data and you have an idea of how many patients are at your specific institution for, let's say, stroke that had atrial fibrillation, if that's what you're looking at, you need to make sure that we're also looking at the co-enrolling studies. So this, I think, is more common of an issue at larger centers that are performing multiple studies at the same time. But if you do have other studies that are enrolling the same specific patients as you, this might mean that your feasibility data doesn't reflect the true number of patients you could enroll, because again, some of those co-enrolling studies might be taking some of that same patient population. So something good to keep in mind. Now, cost was up there for one of the barriers, and again, resources, making sure that you have the staff. So there are definitely some hidden things if you've never done research before that are kind of surprising. You have your IRB fees. Some institutions charge overhead fees, and that can be dependent upon your funding source as well. So I know some major academic medical centers charge up to 62% for industry-sponsored trials. And so making sure that your budget is correct and that you're taking all these fees into account at the very beginning is definitely helpful. You have fees such as coverage analysis, staff time, statistical help if you're having to hire a statistician to work on the project, or any other specialized test or procedures that are needed for that specific project. All those play into account on making sure that you're getting the correct budget and then making sure that you have the correct resources. So a lot of the resources are staff members. So really looking at how much time is it going to take to run this project, how many people am I going to need for that, and then what type of training do they need. We have the institutional review board training here, but also types of training for that project. Is it further stroke training that they need, stuff like that. As far as the institutional review board, so I'm sure most of you guys are familiar with since you're already doing research at your institution. This is the institution or the board that actually approves for research. So the IRB will review your research project. They'll come back with any stipulations saying we need to change these, making sure it's safe for patients. And then that is where you'll actually get the approval to move forward with that research project. So you see the specific training there, and every institution is a little bit different. UT Southwestern, I know they require conflict of interest training as well. Some sites will require ethics training. But in general, the human subjects protection, good clinical practice, and HIPAA are always required. So making sure that your staff members are trained on that. And then if we look at the different types of IRBs out there, so some hospitals have their own IRB. That's what we would consider an internal IRB. And then we have external, central, and single IRBs. All those words are kind of used interchangeably. And this would be if your institution is relying on an IRB outside of your own institution. We'll get a little bit more in detail with that with some of the rules that are changing for 2018. Reciprocity is usually used when you're in a system. So Dr. Warwick is in Austin at UT Austin. He's part of UT system, just like we are at UT Southwestern. And so if he approves, their IRB approves a research study in Austin, we can use reciprocity with UT Southwestern, so we're not doing a full submission here. So if you are in a larger system, that might be something to look into. Reliance agreements are usually when your smaller institutions or other IRBs want to rely on one that's already IRB approved. So both institutions have IRBs, and then your IRB will have to have a federal-wide assurance number, or the FWA number, but then you can file paperwork to not have a full IRB review at your own institution, and you just rely on the outside institution. So almost similar to the central IRB or external single IRB. And then there are some hospitals that don't have any IRB at all. So we've worked with hospitals in North Texas that have participated in some of our multi-site trials that is the case. And for those situations, we can file their staff members and their sites under our own IRB. So that's definitely an option if you don't have your own IRB. And it sometimes saves on IRB cost as well, so that's good. So going back to some of the regulatory requirements, we do have a common rule that is changing. This is coming down from one of the federal regulator sites. And so the common rule is saying that for any federal funded studies or NIH funded studies in 2018, as of the 25th of this month, are going to start requiring a single IRB. So if your site is participating in any of those studies, make sure that you're looking at those guidelines as well. And then maintenance of records. So if you're participating in an FDA trial, there are lengths of time that you have to keep those records. And I think it's a lot longer than what most people anticipate. So it's 2 years following the date when the marketing application is approved for the drug. And then if the application is never submitted or is not approved, it's 2 years after the investigation is discontinued. So there are pretty good websites that are out there just to make sure that you are following the regulations with the federal government. The Office of Human Research Protections is a good place to look. They have great resources on their website. And then we'll kind of go into contracts. So at the very beginning of trials, most investigators are going to send you, or most sponsors are going to send you a non-disclosure agreement. So I'm sure most of you are familiar with these. That's something saying that you're not sharing any of the research information with anyone else. And then data use agreements, any hospital that is receiving your data, you would be filing a data use agreement with. That data use agreement controls how that site can use your data, whether they can share it with other parties, and then how long they can keep it. The subaward contracts or agreements are just basically saying how much you're going to get for the study and what the time frames are for your payments. What milestones do you need to meet before you actually get payment on that? Master clinical trial agreements are usually used in larger networks, so StrokeNet, all of those types of networks. And what you do with those master clinical trial agreements is you have a blanketed agreement where you can just file subaward agreements and study-specific agreements under it. So it will save on time with the contracts piece of it. I feel like it's a little bit more organized than having separate studies for each of them. So that's a little bit about the master clinical trial agreements. And so we'll go into the discussion part and then back to Dr. Wahlberg.
So I invite you to click Q&A section in the top right corner and send your questions. And as we're doing that, let me start by asking Michelle. I believe you said that for you the biggest challenge in establishing a new site, for example, you're starting up a relationship with the emergency room several hundred miles from your own hospital. I think you said that the biggest issue there was obtaining buy-in. Can you walk us through just exactly how you go about that and what are the tricks for being successful in getting that buy-in?
Sure. So we actually have one of our Lone Star sites on the call right now. So Christus St. Michael Atlanta, when we went to their hospital to get buy-in, fortunately they were already participating in some types of research. So that's an example of a great buy-in. It was very easy. The stroke coordinator is very involved in research. In contrast to that, we've had some in North Texas and West Texas where the administration or the research department or even some of the emergency department nurses, were a little bit more resistant to research. And so really meeting with those people one-on-one and explaining how their role in this project can benefit future patient care and outcomes, and making sure that they feel valued and needed, because we can't do research without these people that are on the ground seeing the patients or enrolling them, was a huge step. I know we've worked with some emergency department nurses where they felt like it was, added burden and charting or whatever the case is. And then at the very end of the study, or even at the, once we started, after sitting down with them and hearing their concerns and really addressing that and giving them feedback and letting them know these are the potential benefits of this, really changed the dynamic of it. So it was a lot easier to get buy-in with that one-on-one visiting.
Do you think that your role as training as an emergency room nurse gives you a special advantage in working with a group of emergency room people for a stroke study?
I definitely think so. So there's a different level of, maybe respect is the right word. It's different to have someone outside of the emergency department step in and try to get emergency department nurses to change their practice when they've never been in their shoes. I've run stroke codes in the emergency department, and so I understand the barriers that nurses run into with stroke codes in the ER. So really being able to sympathize with those nurses that are enrolling in these studies is, I think, a huge benefit of mine. Now for the NASCARE study, we also had some neurocritical care physicians and stroke physicians that came out and did education with some of the hospitals as well. And we had, at some of the hospitals, we had some of the providers that actually attended those, not just the nurses. And so I think that also created a different level of buy-in. You have a physician-to-physician conversation about what we're trying to do and what our expectations are and how we think this can improve care. And I think being on that same level with someone or having the same type of training, being able to walk through their shoes is critical.
Question about obtaining and keeping buy-in throughout the course of a study if you're working in a multi-site, doing multi-site investigation.
I'm sorry, you cut off on the very beginning. Do you mind repeating that one more?
That's a question for Dr. Wahlberg. What's your experience has been? You've done a number of multi-site studies, and the question of how you not just gain buy-in at the beginning, but also maintain it throughout the length of the study, what your best practices are in terms of getting that kind of deep and sustained involvement.
Yeah, it's a great question. I think by far the most important way to get buy-in is to stay involved with the site through regular calls or even site visits on occasion, if that's practical. It's no random event that the lead site from which a study originates is always the best enrolling site, or usually the best enrolling site in the trial. And that's because that study is always on their mind. They're always thinking about it. And I think for places that do several studies, it's a matter of always making the study that you're running as important to each study site as it is to you. And it's, it very commonly observe after one of those calls or after a site visit, that site will enroll a patient where they haven't in a while. So I think communication, you can only under-communicate, you can never over-communicate. So being involved with the site, being available for questions, if they're having a problem enrolling or identifying patients, try to understand what their obstacles might be and how you might fix it, but communicating is the key.
I have a question for our two presenters and also for the audience. We heard about quality improvement, and of course we do a lot of our quality improvement through the American Heart Association, American Stroke Association tools that are provided specifically for quality improvement. to what extent do big and meaningful research projects come or start with a quality improvement project? Someone has the idea to improve something about the care of their patients, they try it and ultimately decide that this should become research.
Feel free to come off mute with *6.
Dr. Warwick, do you have a...
Yeah, I'll speak first. I think it's, I think most quality improvement projects don't lead there, but I think many of them do when your attempts to improve the quality by non-interventional techniques don't work. So I think, you know, if it really is a quality improvement exercise, which as Michelle went through very well, is not considered human subjects research. If it's successful, then that will change the practice without having to do a research study. But it's where there is a problem and the quality needs to be improved, and the non-interventional type of approaches haven't accomplished it. That's when we start looking for examining that more rigorously with randomization or other more specific interventions that might involve medicines or devices.
Okay. Unless the two of you have further comments, I'd like to move on to part 3.
So we do have a question at the top there, Dr. Goldberg.
Why am I not seeing it?
So it says, do you wait for a stroke neurologist to bring research trials to you, or do you recommend, as a stroke coordinator, being proactive and looking up possible trials to participate?
Would one of you like to take that on?
Yeah, I'd say both. I think, you know, once you're known as a site that does research, you get approached. But through contact, through going to, you know, the American Stroke Association meetings, learning about research that you're interested in, I think it's, you know, you often are taking the initiative to want to participate. And then, of course, you know, depending on your inclination and resources, you may be the one who makes a proposal either to a company or to NIH or American Heart Association to do a new clinical research project. But it's, you will be approached if you have a large stroke center or if you've, you know, got a reputation as a stroke clinical research site.
Now, I'll make one more comment before we go on. This is for the folks in the states that aren't Texas. Dr. Warwick makes it sound easy getting funding from the state of Texas, which certainly was not. We were fortunate, very fortunate, that all things came together as they did. And the other point is that the regulatory world that we live in makes it very difficult to do research across many sites, many kind of different hospitals, because in many worlds, these things just don't interact. There's different IRBs, different contracts, different lawyers getting involved. And I think the future we're all looking for is a world in which these things kind of tend to come together, and there's been a lot of progress towards that. These have to do with the idea of using a single IRB and not a different IRB for each hospital, the idea of using common contracts, common data sharing agreements. And the more of this that happens in your state or in your network, the easier it's going to be to put together large research projects that take advantage of the existing network you have. So I think our answer has been, don't take no for an answer. Keep working through it and hope that as things, as time goes by, that this process is going to become easier and more streamlined. Okay, with that, we will turn to part 3. Back to Dr. Warwick.
Yeah, and follow up on Dr. Goldberg's last point. It's we're always looking for a way to either proactively or retroactively get around obstacles, because they're there. This is hard to do. Clinical research, it's hard to do it well. So in this next part, I'm going to engage you all in helping to design a clinical trial, which brings together a lot of the points that Michelle talked about earlier. But in the following way, so it was really convenient and not surprising that the three obstacles that people most identified was cost, the time it takes to do studies, and then you may not have enough patients. So as we were contemplating what would be ideal for the Lone Star Stroke, what's a study that could be done at any hospital that would not require a lot of cost and a lot of time, we struggled to come up with a question that would meet that. So I'm going to focus largely on this issue of the clinical research question, which was one of Michelle's points, which I would call the so what question, right? You could answer a question, but it's not going to make a difference in the daily practice of taking care of strokes, so what? So we have this idea of a trial that we call START. It's not an acronym, but it refers to the main question of when to start oral anticoagulation after an ischemic stroke in somebody that had a stroke due to atrial fibrillation. One advantage right there, we encounter these patients all the time. It's a very common scenario, and there's no clear answer. The practice patterns are really highly variable. We'll get to that in a moment. But what do we mean by the optimal time? So there's two factors. One, if you delay starting anticoagulation, you may increase the risk of having a second stroke before you start it. If you start too soon, there's a concern that you turn an ischemic stroke into a major hemorrhagic transformation. And so the guidelines that we have give us a range of between 2 and 14 days, and so the treatment choices really for practitioners are all over the map. So one question in trying to design a trial is the question of what's worse, another ischemic stroke or a hemorrhagic transformation? So we're going to open up this question now for your answer. I'm not going to answer these, obviously, because I want to know your opinion. I know my opinion already. Because this is important in the design. Do we give more weight to preventing an ischemic stroke or more weight to avoiding symptomatic hemorrhage, or equal weight to both? They're both equally bad. Which is C is they both sound equally bad to me. Think of it that way. And I don't know how many have voted so far when we close it out. But what do we have so far, Larissa?
Both sound bad to me. Yeah, the most answered, the most response.
So can you give me the relative numbers?
13 of the 42 that were on the line. About 25 didn't answer, so we're...
Okay, we only have 42 that can vote.
Yeah. About 31%.
31% said C. How many said A and B?
7% for A and 2% for B. And then we had 60% who did not answer.
Okay. So most gave it equal weight. That's useful. Okay, I'm trying to advance. There we go. As I said, the current evidence in the American Heart Association guidelines say that there's no clear difference anywhere between the first 14 days. So, there's two questions. One is, if we're going to investigate this, do we take any anticoagulants, or do we study warfarin or the newer oral anticoagulants separately? So, question to you all who are involved in treatment, and if you're not the physician treating, you know what the general practice is at your place. Do you tend to use warfarin, tend to use one of the newer oral anticoagulants, like, Redaxa, Eliquis, and so on, or not your area, so you're not going to answer? And how are we doing on that?
26% said B, one of the newer anticoagulants, oral.
Yep.
And then 12% not my area of expertise, and then warfarin.
How many said warfarin?
10%.
Okay.
That's 4 of our 2 participants.
Very good. That's great, because we are looking in this trial at the NOACs, at the newer ones, with the belief based on our own experience that is becoming more and more popular to treat. So far, the crowdsourcing of this design is matching what we thought. Now, for those that are involved and know what the usual practice is at your site, what is the usual time to start oral anticoagulation after a stroke? And within the first 3 days, 5 to 7 days after the stroke, 9 to 11 days after the stroke, 14 days, meaning 2 weeks or later than 14 days. What's typical for your hospital, for your physicians? I'll let 30 seconds elapse before I ask Larissa.
All right, we're right at about 30 seconds. Within the first 3 days, 31%.
Okay.
And then
what do you have for the other ones?
So, sorry, WebEx is tallying them.
Okay.
So let me get back to my screen. We were tied for 7% for 5 to 7 days and no idea. And then about 2% said 14.
Oh, what's the total number of people that answered?
22. So about half of our people responded.
Okay. Well, that's interesting. Maybe we don't need to do the study. Everybody's already getting it early, but we actually don't have data on that trade-off. So this may relate. So is a so what question? Would a clinical trial that identifies a day to start anticoagulation and minimizes the risk change your practice? Definitely yes. Probably yes. Possibly. Probably no. Definitely no. You don't care what the study shows. You're going to do it your way. And what's it looking like?
We had about 29% say definitely yes, 17% say probably yes, and 12% say possibly.
Okay, that's good. We got a bunch of scientists that if the data shows you, you're going to do it. Trying to advance. I know I'm trying to wrap up. I just can't advance this thing.
There you go. Now you should be able to.
Okay, I think, so here's the real question. Would you be willing to randomize to a NOAC between 2 and 14 days. So your patient might not, they'd be on an aspirin, but they might not be able to start their anticoagulant for 14 days, or they might have to start as early as 2 days. Would you be willing to randomize those patients? This is going to be my last question. And the answer is what do we got?
So the majority said yes, followed by no, and then 4% said about 4% said I'm not involved in these decisions.
Well, I'm pleased that we've got a group of clinical scientists who are willing to randomize even though it goes against what their current practice is. That's what clinical research is all about. It's a nice way to bring closure. So let me tell you, and you know, this isn't just curiosity or fun. We're actually involved in designing a trial that uses stakeholder input. Use stakeholders, the stroke coordinators, clinical researchers, clinicians, as well as patients who are going to be surveying to get an idea of what matters. It's the whole concept of designing trials where the outcomes are those that matter to patients and other stakeholders like practitioners. So thank you for your participation. I think you will hear more about that trial in days to come, I believe. And we're all open for questions now. I'll turn it back over to our MC, Mark.
And I would like to thank you all for participating, and I certainly want to thank our two presenters, Dr. Warwick and Michelle Provencher, and to Larissa for hosting this. This has been a great pleasure. We are certainly available by email to you anytime for more discussion, participation, collaboration, and we look forward to continuing with the Southwest Affiliate webinar series to come. Thanks again to everybody, and with that, we'll say farewell. Bye-bye.
Thank you.